So I've asked John to begin by introducing himself and saying a little bit about how he's come to be where he is. So we're not going to clap and all that stuff yet. We might do that at the end. So, John, over to you.
Thank you very much,
Can I ask
Julie.
you to turn your phones off, please?
Thank you, Julie, and thank you, Jesuit Social Service, for asking me to speak. So I'll begin, and I'd like to also acknowledge the Wurundjeri people on whose land we're gathered today. Beginning with a bit of a personal history. I mean, I grew up in Melbourne, went to Xavier College, and was influenced very much early on by Ignatian spirituality. And I think I maintained my links with the Jesuits after I left school through medical school. One of the important things that led to in my own personal development was I used to work at The Way, which is a house for skid row alcoholics in Gertrude Street, Fitzroy, run by the Jesuits. One night a week, I'd go there from 11 o'clock and spend the night looking after those men while I was in medical school. And the reason that's important, I think one of the things that one of the geniuses, I think, of Ignatius was his insight that reflection on experience and actually our emotions and deeper parts of ourselves are very important in terms of trying to find out what it is that gives us depth of meaning in our work, in our lives. And so by being able to compare the experience I was having working in a large teaching hospital, once I graduated I was at the Alfred Hospital planning to become an infectious disease physician, but being able to compare the experience of that work and the depth of meaning that perhaps I wasn't experiencing that with what I felt while I was just basically working, not using all my skills, but working with some of my skills in this house in Gertrude Street, was one of the things that made me realise, well, perhaps I don't want to have a life of working as an infectious disease physician in the Alfred. Maybe I want something else. And so I took a year off. I managed to get permission to take a year off from the training program, which wasn't easy to do. It took a lot of lobbying and a lot of, because I wouldn't have gone if they hadn't said I could come back to become an infectious disease physician. I would have said no, I better not risk it. But in the end, they gave me 12 months, and in that 12 months, I planned to go to India to work in a Jesuit mission hospital. But when the time came, I didn't have a visa, and there were all sorts of issues in medical officers getting visas. So again, a Jesuit friend said, look, they knew of a health service in Tennant Creek where they didn't have any doctors, an Aboriginal health service. He knew the director, an Aboriginal woman called Chris George. He said, you might as well go there, which I did, and went there. And then once my visa came through India, I'd stayed because I suddenly realised the level of need which was there, which previously I had no idea about. I hardly ever met an Aboriginal person. All the way through medical school, there was nothing then about Aboriginal health. I'd met one or two at the Alfred Hospital, but I was just blown away by my experience in those first few weeks, and also meeting people who'd been overseas and said there's no point going anywhere for 12 months or even 2 years if you can't speak the language. Stay in Australia, work where you are. So I decided to stay there for the year, and I'm still there 24 years later, and I worked in Tennant Creek for 6 years, and then I've gone to Alice Springs. But I think that process of reflection on experience and discernment, and actually trying to get in touch with more than just the rational side of yourself, but how you actually feel about the work you're doing and how meaningful it is, was very important, and that was something that the Jesuits instilled in me, which has been very valuable throughout my working life. Now, what I'm going to talk to you about today is really a paper that the Central Australian Aboriginal Congress produced in about April last year. It's available on our website. It's called Rebuilding Family Life, the Social and Community Dimensions of Change for Our People. And it was really designed to say to the Commonwealth Government what we think are the most important next steps beyond the Northern Territory emergency response. The paper has 10 main parts to it. I'm not going to talk about all of that, I haven't got time today, but I'm going to focus on early childhood programs first, and the importance of early childhood, alcohol, particularly alcohol supply reduction, and income inequality at the end. But briefly in the beginning, I'm just going to give you a brief overview of contemporary Aboriginal health status. 12% of the Aboriginal population live in the Northern Territory. That's around 55,000 Aboriginal people. And one big difference in Aboriginal communities is the age structure. At Congress, we have 7,500 current patients, and 48% of those are under the age of 25, which is similar to this profile here. There are many, many more young people and nowhere near as many old people. That has important implications for early childhood and child rearing and the level of support that parents get, which is one of the things that I think is most important and needs to be addressed. In terms of life expectancy at birth, recently there's been a major improvement because we've got better with statistics. So instead of a 17-year gap nationally, We now know the gap's very different in different jurisdictions. In Queensland, the gap's about 8 years. New South Wales, it's about 10. In the Northern Territory, it's still 17. So the national gap's now 11.5 years, not 17 years. But the NT, it's still 17 years. But importantly, in the Northern Territory, if you go back over the last 30 years, male life expectancy has improved from 52 to 62 years. Female life expectancy has improved from 54 to 68, 69 years. So that's a 14-year improvement for women and a smaller 10 or 9-year improvement for men. So things have improved. The gap's getting bigger for men, it's getting smaller for women in the NT. So it is important to realise things are improving. The major reason for that improvement is the improvement in the health system. The social determinants beyond the health system have not improved in that time. So really, we're doing a much better job at treating conditions, keeping people alive with illnesses, but we're not preventing them to any large extent. This is the Northern Territory in particular. So 77 or 88, now about 80% of that gap, 17-year gap, is due to chronic diseases. It's due to coronary heart disease, diabetes, renal disease. That's the major reason for that gap. And the deaths that occur in those areas are mainly in midlife. So communicable disease accounts for 10%, infectious disease about 10%. So in the old days, babies died, but if you got through early childhood, you lived a long life. Nowadays, babies are surviving really well, but in terms of the quality of care and the brain development and other things they get to set themselves up for a long, healthy life, that's what's not happening at the moment. And so there's been a significant change in what's going on. And if you look at the objective markers, infant mortality in 1973 when Congress started was 120 deaths per 1,000 live births. It's now around 12. So there's been a big decline, as I said, in the death rate amongst children. But in terms of the quality of care and the development of children, that's the major issue now. And I want to switch to talking about early childhood and its key importance in Aboriginal health. Where there's a heap of evidence now showing the importance of early childhood. This study, which is a major study, showed that 54% of depression in women could be accounted for by adverse events in early childhood, and a whole range of other mental health and addictions that develop later in life, as well as physical ill health, can be accounted for by adverse events in early childhood. This from Michael Marmot last year, the British he studied 70,000 British babies, all born in the same week in 1970, and followed them for 30 years. And he showed, importantly, that IQ amongst low socioeconomic children drops off very quickly in the first 3 years of life, and amongst high socioeconomic children gains very quickly in the first 3 years of life. And he looked at the things that made a difference in his study were things like being read to every day, conversational language in the home, routine, regular sleep, physically active kids, playgroup, good friends, good playgroup of children to work with. Sort of good quality parenting in early childhood is what made the difference in both the loss of IQ and in fact the loss of brain potential, but also in gaining it. We've also seen that from Hart and Risley's classic study, where they showed that this massive difference in spoken language in the homes of professional families versus welfare families, such that by age 4, children have been exposed to 32 million more words, and words of different complexity. So conversational language is incredibly important and makes a huge difference in early childhood and brain development. But also children in the professional families had positive reinforcement compared to the children in the welfare families, where they had 150,000 more negative affirmations. So there's this very big difference going on in the way the way children are being brought up in low socioeconomic families compared to better off families, in families where parents are better educated compared to where they're not, which is one of the big issues in Aboriginal health at the moment. This study from last year shows the importance of self-control as measured in early childhood to lifelong health and well-being, and also development of addictions. So in this study, there's a direct relationship between the level of self-control. So low self-control in childhood, much more likely to have physical health and substance abuse problems later in life. And we believe, for many years when we looked at young people suiciding in Aboriginal communities, we used to think they got drunk and then became impulsive, and suicide was an impulsive act. It doesn't happen in people that are clearly depressed. There aren't the normal warning signs. It's quite an impulsive act that happens when people are drunk and depending on access to a particular weapon. But now we know impulsivity comes first. That is prior to the development of addictions. And so the combination of impulsivity, lack of self-control, and then addictions is dynamite. And that needs to be seen as a risk factor, not depression. Again, in the Australian recently, this is a study, there's many studies I could have quoted, but this is a very recent one from the Australian Institute of Family Studies, again showing the big gap that's opening up in low socioeconomic kids compared to higher socioeconomic kids in brain development, IQ. And this has been getting a bit of publicity in the Australian this year. There's been quite a few articles. This is a quote from Frank Oberclay, basically saying that we have to turn our attention to the first 5 years, and in fact the first 3 years of life. That hasn't been happening in the Northern Territory. Even the preschools that have been set up and funded in Central Australia, they're not staffed with preschool teachers, they're staffed with local community members who don't even have Certificate 3 yet, and that's called a preschool. But that's as far forward as they've gone, and that's a big problem. This highlights the disadvantage. This is the Australian Early Development Index, which is a fantastic tool that Frank Oberclay and a former Australian of the Year, Professor Fiona Stanley, adapted from Canada for Australia, and it's now being done every 3 years. It was done for the first time in 2009. Children that are developmentally vulnerable on 2 or more domains at age 5 are very unlikely to complete Year 10 based on longitudinal data from Canada. So on this index there's 5 domains, the physical domain, and all these domains are important. IQ is just one. The emotional, as I said, self-control, conscientiousness, they're things that matter in terms of health and well-being throughout life. Other domains of brain development are equally important. Well, Aboriginal kids in the western side of the highway in Central Australia, 80% of Aboriginal children in the first year of school are developmentally vulnerable on 2 or more domains. And the eastern side of the highway, it's also very high. In Alice itself, this isn't broken down by race, by Aboriginality, unfortunately, at the moment. So that data for Alice Springs represents all kids, but having now been shown the data for Aboriginal kids, in Alice about 40% of kids are developmentally vulnerable on 2 or more domains. So really, the chances of turning those kids' lives around after age 5 are very limited. A major review article just published in The Lancet, which reviewed the world literature on all interventions after age 5 for kids that are this disadvantaged, didn't show any measurable effect from any intervention at turning children's lives around after age 5 if they haven't developed their brain potential. Because 80% of brain developments happen by age 3, 92% by age 4. You can, with a lot of intensive work, make some difference after age 5, but it is incredibly difficult. This then highlights, if you've got kids entering school with that disadvantage, this is what you get at the NAPLAN level at Year 3 for the Northern Territory. Kids are miles behind. If that was broken down by Aboriginality versus non-Aboriginality, which it isn't, you'd see much worse results for the Aboriginal kids. The average level of literacy for children in remote Central Australia is still Year 3, and the participation rates in education haven't changed in spite of the intervention. The good news is there are some interventions that make a big difference. One of them we finally got funded after 10 years of lobbying for in Alice Springs, which is the OLS Nurse Home Visitation Program, which basically visits all children, all mothers from the moment they're pregnant to when the child's 2, assigning a nurse to that mother, and it's a very holistic program. There's 6 domain areas. It's a program around personal development and around addressing a whole range of social environment issues in the house, not just only one domain is about direct health issues. And now we're doing that in Alice. We've now got more than 100 mothers on that program. The first 3 children have graduated from the program after 2.5 years. And those kids at age 2, the thing that everyone commented on recently at the graduation was their language. How much people were walking around saying, look at how these kids speak, which people notice as being very different. So we're hoping we've got good signs of success in terms of improvement in birth weights, and birth weight's critical. 20% of the midlife chronic disease premature death mortality rate is due to low birth weight. So that all these things matter, and there's some good signs from our data, and we're collecting good data on this program. That is an intervention we know makes a difference. Randomised controlled trials in many different countries have shown these sort of outcomes for the OLS Nurse Home Visitation Program, but particularly long-term follow-up for children at age 15. They're 3 times as likely to still be in school. They're much less likely to have addictions of all types, much less likely to have multiple sexual partners, 70-80% less likely to be in trouble with the police. So it has major impacts over a long period of time. It's only happening in Alice Springs and a few other selected places around the country. It was happening in Melbourne, but it's fallen over, which is very unfortunate for Melbourne, but it is working very well in Alice Springs. The other program that makes a big difference is Joseph Sparling's Abecedarian program, which is educational daycare. So as well as trying to work with parents in the family to do what you can to support parenting and to support a better early childhood environment, he also believes that there are many families, or some families, where your best efforts are not going to lead to much improvement in the household. So he argues, as well as that, you take children from disadvantaged families out and put them in educational daycare almost from birth until they're 3. And in that educational daycare, you have to have one care to 4 children, and you have one-on-one sessions with those children, 15-minute sessions, 3 times for each session they're there, where you're promoting learning games, conversational reading, and a whole range of things to promote brain development. Again, he's done randomised controlled trials which have shown this. The control group, by age 3, again, 49% of kids in the control group had an IQ less than 84. So these are all children from very disadvantaged families. Single parents, low income, multiple drug problems with parents, mental health issues, the same sorts of profiles. The kids are losing out big time by age 3. The kids in the intervention, nearly 100% of them had an IQ greater than 84, and other major measurable impacts on brain development in the emotional and social domain. So that's an intervention that we know makes a big difference. We're now working with Joseph Sparling to set up a major research study in Alice again, but it's not happening anywhere else. So that's early childhood. And also the impact that early childhood has on subsequent health issues in terms of the development of alcohol problems and addictions is very significant. I just want to talk now briefly about what we've been doing in the area of alcohol, because that's another major issue in Aboriginal communities. The Northern Territory, they've attempted to quantify the impact that alcohol has, and this study was quite a recent study which looked at $642 million per year. But this study doesn't even attempt to quantify the impact that alcohol-addicted parents have on the lack of development of their children. So that's not even factored in, because we haven't worked out exactly how to measure that impact, but I think it's the most pervasive impact of all. If you look at the life chances of a child born into a family where one parent's addicted to alcohol, that's the biggest impact that it has. It's not even factored into that analysis. So what can we do to reduce alcohol-related harms? Supply reduction at a population level, demand reduction in terms of treatment, and harm reduction. I'm just going to focus largely on the first one today. But we've known for a long time. I read this article way back in 1988, the first year I was in Tennant Creek, and then when I went to Tennant Creek, the place was awash with alcohol. They had sex shows in all the main pubs, strip shows, attracting people into the pubs to drink alcohol. That was leading to huge problems in terms of women being raped on the way home, because they had local women getting up, dropping their top for $50 grog voucher, and those women were targets. A 15-year-old boy who went to one of those shows in a public bar raped his school teacher on the way home. So as a GP in the health service, I was seeing these people as patients, and we made the connection very quickly. We ran a campaign which was very successful quite quickly, got rid of all the government legislated to make a code of ethics about how strip shows were run. Once that code of ethics became law, the strip shows didn't make money, and they actually stopped happening and haven't come back since 1989. So that was useful. But I think that more importantly, this paper really highlighted the key public health, population health measures that are going to make a difference, and price was the most important of all in terms of preventing alcohol-related harm. That's been backed up. This is a report by the WHO in 2003 by Barbara and others, which examined the international literature against 4 criteria: effectiveness, strength of the evidence base, cost to implement, cross-cultural testing, and they looked at interventions in many different countries all over the world. The single most important determinant of alcohol consumption and harm was price, and the WHO in March 2010 launched their strategy, global strategy on alcohol. The single biggest factor in that strategy is to increase the price of alcohol through either a volumetric tax or a minimum floor price. This study done by the University of Sheffield is what's guided the new Scottish government, which just came to power, has won the election on a platform of introducing a floor price in Scotland at 70p, which we're expecting to do very soon. This study by the University of Sheffield quantifies a minimum price of 40p, which is only 70 cents a standard drink, what impact that would have in terms of population health, prevention of homicides, prevention of hospital admissions, reducing consumption. The evidence is overwhelming about the impact of price. Again, this has been picked up by our report by the Preventative Health Task Force. which highlighted the absurdity of our current taxation. The wine equalisation tax taxes alcohol, taxes wine according to quality. So the cheapest wine is not taxed at all, which is the cask wine, whereas the more expensive, the higher quality the wine, the more it's taxed. That's not what we need. We need to make this wine sells at 25 cents a standard drink, which is just causing so much harm. This study in the Lancet from last year showed that in France, over 30 to 40 years, through an agreement between government and the industry, they got rid of cheap wine. And the more French winemakers only make quality wine. They compared the impact that's had on consumption and mortality in France to Great Britain, where the opposites happened. Great Britain's deregulated everything, including alcohol. The alcohol market, thanks to Maggie Thatcher, doesn't quite come out in the film. If you go and see it, I wouldn't go and see it, it's a great disappointment. It almost makes Maggie Thatcher look like a hero. But importantly now, even the wine industry, this is the Journal, the Winemakers Journal, this guy has become a leading advocate for a floor price. Okay, and so in Alice, what have we done to implement some of this? We set up the People's Alcohol Action Coalition in 1995 after a public meeting convened by the late Charlie Perkins, and PAC's been quite effective at advocating for a range of policy measures, including the introduction of price-based supply reduction. I won't go into the details, but basically it wasn't perfect, but it did get cheap grog off the market between 2 and 6, and the only grog that's available after 6 was 2 litre casks, which sold at 50 cents a standard drink, which doubled the minimum price and dropped consumption by 18%, and there's been a measurable impact. Serious harms dropped by 20%, and other things have improved as well in Alice, and that's been a useful thing. This debate goes on. Surely, some people argue Aboriginal people aren't affected by price. It's rubbish. They're as affected by price as every other person in the world from all those studies. Unfortunately, though, in Australia, alcohol's cheaper than water. You can buy a bottle of wine at Clean Skin at $1.99, which takes 1,000 litres of water to produce that wine, and it sells cheaper than water, and that's doing a lot of harm. But in Alice, Coles and Woolworths have agreed, and all the supermarkets have now agreed, to set a floor price at $1.15, but unfortunately it's not being followed by the pubs, and that's backed by the Australian Competition and Consumer Commission, has recognised the importance of regulating and not opening up the market to competition for the purpose of setting a floor price because of the public health benefit. But in Alice, we still have these cars being sold by the 2 pubs, so they haven't agreed to the floor price, so it's difficult to get this implemented voluntarily, which is why we need government to act. But there now is a move to set a voluntary accord in Alice Springs, which may bring the 2 pubs online. I won't go into this is another thing that's happening in the Northern Territory, is a major, huge reform in demand reduction, and this is an alcohol program that Congress delivers, a treatment program which is attempting to do a lot in the area of demand reduction based on 3 streams of care. I won't talk about that. I just want to finish by saying something briefly about income inequality and what we can do. Income inequality is a major aspect of population health worldwide. Countries that have more inequality have worse health. Australia has never been richer. Our gross domestic product's now gone up to $1.3 trillion. In spite of that, we've got growing inequality. There are more millionaires, the highest number of millionaires created in 2010 in Australia. It matched the previous highest, and that's in spite of the global downturn. We're a very low, if you look at the OECD average, Australia, taxation revenue in Australia is only 30% of GDP. Even if we increase it to the level of Canada, which is here at 34%, that would be an extra $16 billion of government revenue. This is important because the money that's needed to implement the sort of programs I've talked about is there if we're prepared to tax the rich or introduce things like the Tobin tax, which Angela Merkel's now saying the European Union's going to do. There's a whole range of things we could do to increase that revenue, but we have to do it. This is a big part of the problem. The income gap between Aboriginal and non-Aboriginal people is still huge. And recently we had the World Economic Forum just in the paper in January saying that they can't bring themselves to use the word inequality, so they use the word disparity. But there's now widespread recognition that the massive income inequality has caused the global financial crisis. And it's causing major issues, but if we're going to find the money to do what's needed to address Aboriginal health, and we have to address multiple fronts at once, then we're going to have to do something about increasing taxation revenue through a range of measures. So in conclusion, this paper, which I based this presentation on, has a range of recommendations at the end of it, which is there. They're the sort of things we think are going to be needed to move us to the next level and address Aboriginal health. So with that, that's, if you like, a quick tour through a number of presentations which I've just tried to give a bit of an overview of quite quickly.
Thanks, Tom. And that's huge, isn't it? There are not lots